My name is Terry King. I'm the Chief of the Division of Breast Surgery at Brigham and Women's Hospital and Dana-Farber Cancer Center in Boston, Massachusetts. When discussing the role of contralateral prophylactic mastectomy with a patient who's been diagnosed with an early stage curable breast cancer, it's important to discuss all of the risks and benefits of the contralateral prophylactic procedure. We do know that some women undergoing contralateral prophylactic mastectomy will in fact be found to have a small occult either DCIS or invasive breast cancer in that contralateral prophylactic mastectomy specimen. Though the likelihood of whether a patient will be found to have an incidental breast cancer certainly depends on her underlying risk. So women who are at elevated risk, such as mutation carriers or those with a previous history of high-risk lesions, may be more likely to be found to have an incidental breast cancer in the prophylactic mastectomy specimen, whereas most average risk women will likely not. When you look at series in the literature, the older series reported about a 5 to 10% incidence of identifying an occult breast cancer in a prophylactic mastectomy specimen. And that led many surgeons to consider the role of sentinel lymph node biopsy at the time of contralateral prophylactic mastectomy. Certainly, we know that if you've performed the mastectomy and the pathologist identifies an occult cancer, you cannot go back and perform the sentinel lymph node mapping and biopsy procedure. The breast needs to be intact in order to identify the sentinel nodes. So in the setting where you have a perhaps 5 to 10% risk of identifying an occult cancer, performing a sentinel lymph node biopsy may seem to be worth the risks of that procedure. Given weighing the risks of the sentinel node procedure, we know there's a 5% risk of lymphedema with that approach. So again, if you're expecting a 5% risk of cancer, then you may justify the 5% risk of lymphedema with the sentinel node procedure. But in more modern series where high-risk women are often undergoing screening MRI, and we have better imaging techniques, the likelihood of finding an incidental cancer in the contralateral prophylactic mastectomy specimen of normal risk women is certainly lower than 5%. And in high-risk women who've been screened with MR, the likelihood of finding an incidental cancer in the contralateral prophylactic mastectomy has also been shown to be much less than 5%. So when weighing the risks and benefits of performing a sentinel lymph node procedure, if the likelihood of identifying cancer is smaller than the risk of lymphedema, then we really want to consider who really needs a sentinel lymph node biopsy in the setting of contralateral prophylactic mastectomy. There have been many papers written on, again, the cost benefit, the cost savings of doing sentinel lymph node biopsy on everyone receiving a CPM, on also then doing it on selective women receiving a CPM, and never doing it at the time of CPM. And of course, the challenge with never doing it is that if your patient is found to have an occult cancer, then your only opportunity to go back and stage the axilla is to perform a complete axillary node dissection, and that is certainly associated with a higher morbidity than performing a sentinel node biopsy. So in my practice, again, I want to consider the underlying risk that I believe that my patient has for harboring a occult contralateral breast cancer. Again, in many of our patients who are coming in with newly diagnosed breast cancers, they are having MRIs for evaluation of extensive disease of the index case. And so that certainly gives me the opportunity to review the contralateral breast to make sure that the likelihood of an occult malignancy is low. Or as I said, again, if my patient is a high-risk patient who's been undergoing MRI screening, then again, I use that most recent MRI of the contralateral breast to make an assessment of what I think the risk is or the possibility is that my patient might harbor an occult cancer in the contralateral breast. If my patient has a normal MRI of the contralateral breast within the last 6 months, then I do not perform a sentinel lymph node biopsy at the time of the contralateral prophylactic mastectomy, as the data does not support that is associated with cost savings or necessary for the care of the patient. The likelihood of finding an occult malignancy if you've had a normal MRI within the last 6 months is less than 2%, and the majority of those malignancies are at DCIS, where you wouldn't need to know the status of the sentinel lymph node. So if the likelihood of finding an occult malignancy is less than 2% and the risk of the sentinel lymph node biopsy procedure is 5%, then I counsel my patients that the risk-benefit ratio does not support doing a sentinel lymph node biopsy in their particular situation at the time of contralateral prophylactic mastectomy. If for some reason I have a high-risk patient, a known mutation carrier, for example, who's unable to have an MRI. Perhaps they have severe claustrophobia, perhaps they have a pacemaker. If I have, a known high-risk patient who I'm unable to get an MRI of that contralateral breast prior to the contralateral prophylactic mastectomy, then I would likely err on the side of performing the sentinel lymph node biopsy procedure, again, because in that case, if the likelihood of identifying an occult invasive cancer is sufficiently high, exceeding in at least the 5 to 10% range, then I really want to avoid the potential for needing to return to the operating room and the morbidity of an axillary lymph node dissection. So to summarize, I use my a baseline judgment of what I think my patient's risk of contralateral breast cancer is in this particular setting. If my patient has had an MRI for the evaluation of her index cancer, I certainly use that in the evaluation of the contralateral breast. Or if I am taking care of a woman who's been undergoing high-risk screening at the time of her diagnosis, again, I want to ensure that I've had imaging of that contralateral breast within the last 6 months to ensure that it's all normal. And then if I do have normal imaging within the last 6 months, then I will omit sentinel lymph node biopsy at the time of CPM. If there's anything abnormal or questionable on that imaging, then I will perform sentinel lymph node biopsy at the time of contralateral prophylactic mastectomy.